So I'm Carolina, and I'm going to talk about cardiology, particularly congestive heart failure. The thing that y'all need to know about me is I am patient. If I ask a question, I can and will just stare at you blankly until I get an answer. So please do. Okay, what is CHF?
Congestive heart failure.
Awesome. What does that mean?
Diastolic heart failure.
Okay, what does that mean?
Comes from my family.
Okay, go on.
Weakened.
Okay, it's weakened, meaning what? It can't pump. And that is, did you just read that off the slide? Okay. So yeah, it basically means that the heart isn't pumping for whatever reason. And it comes in two different forms, systolic and diastolic heart failure. And then I have pictures to demonstrate this further. So systolic heart failure, you have a heart muscle that is super weak, kind of floppy, almost like a old deflated balloon. It has given what it had to give, and now there's no oomph in it. It doesn't stretch back. So once you pump blood into the heart, it just can't push it out. So you get this old kind of blah balloon. Diastolic heart failure is the opposite. This is like a brand new balloon that you're trying to push more air into, and it just simply won't go. So those are big thickened heart muscles that you can't get much blood in, therefore there's not that much to pump out. And one of the things that we look at with congestive heart failure is the ejection fraction. So how much of the blood that goes into the heart actually gets pumped out. It's never 100% because we don't want the heart empty, but a normal ejection fraction is about 65 to 70%. You can come in. But with diastolic heart failure, you'll get a normal ejection fraction. It's just that you're just not getting a lot of blood in. So a decent percentage of it is getting out, but you're not getting it in. This is the opposite. You're getting a decent amount of blood in, you just can't actually pump it forward. So, why? Why? So I have the list over there on why, but why does coronary artery disease cause CHF? Not everybody all at once now.
Coronary artery disease.
I'm sorry?
Coronary artery disease.
Yeah, why does it cause CHF?
Because it makes it harder to push blood out, and it makes the muscle stronger, so you get less ventricular hypertrophy.
Yeah, so kind of all of these end up going down like a very similar pathway. So you have the arteries around the heart blocked, the heart muscle is being starved of oxygen. You can't pump forward if you don't have oxygen, so that's why. So like a chronic low-level coronary artery disease will do CHF, just like a big MI. If the big MI is knocking out a huge portion of the heart muscle all at once, coronary artery disease can cause the MI, but can also kind of do it at a low level over a long period of time. What about hypertension? Why? Too much pressure on the vessels, but why would that cause congestive heart failure? Yeah, so now the heart muscle has been working for potentially years and years and years, pushing against these thickened, hardened blood vessels. And so it's been working really hard. It either gets super essentially jacked and you get the diastolic heart failure, or after a while the muscles just can't anymore, and then you get the systolic heart failure. But quite frankly, any problem with the heart and a lot of problems with the lungs can actually lead you down the path to congestive heart failure. So if a patient ever tells you that they have CHF, that's not the only problem. There's something else going on, or at least there was something going on prior. So, how would your patient present? I gave you the answer to that one. But why? The lungs are full. So yeah, you have this in the human body. Right, so you have the blood backing up in the heart into the lungs, and from there also back into the legs. So that's why this. Now what is orthopnea? It's a big fancy word. That means they can't breathe when they're laying down. Why? Yeah, so particularly when you're full of fluid, if I'm standing up, cool, no big deal. Gravity's keeping the fluid right down around my lung bases. I still got a lot of lung to work with. If I lay down, that fluid layers out, gravity. always. So now it's taking up more of my lungs and it's making it harder to breathe. So that patient who says that they can't lay down and breathe, they're legit, they can't. Okay, so that causes acute pulmonary edema, so APE. And this actually can cause chronic pulmonary edema too, which is a whole different animal, and we'll get to that one. So, fix it. How do you fix it? I heard CPAP, Lasix, louder and more with more commitment, nitro. And we're actually, this next little bit, we're actually going to go through different treatments and how jazzed you should be about them. Because there's a lot of them, but not all of them have the same efficacy. And there's stuff that has actually come in and out of favor recently, particularly concerning APE. So, y'all's protocol. So, full Fowlers, why? Y'all gotta quit mumbling, I'm struggling. Commit, what was the answer?
Yeah, sit them up.
Sit them upright, why? They can breathe, why is it, why? Gravity, yeah. So gravity is keeping the fluid in the base of their lungs. You can actually use gravity to your benefit. And then why the Wall-E picture?
Because they're overweight.
Yeah, so this is exactly it. More and more people have more body habitus. And quite frankly, it becomes difficult for patients to actually move the weight of their own chest wall. So when they're laying flat, again, it's a gravity thing. It's more difficult to move when you actually have them sitting up. The respiratory mechanics are better. They can move air better. That patient who's in like the tripod position, why?
Can't breathe.
They can't breathe. And on top of that, when they do the tripod position, that actually allows their body to use more accessory muscles. So they're trying to help themselves. If you take them and lay them flat, you have now taken that ability away. So sit them up, bolt upright, because it helps. So do it. What about oxygen? I heard a chia. Any dissenting opinions? Everyone's chia.
Pretty much.
Okay, why?
You're having trouble getting it to get it away.
Yeah, so these people are having a problem with oxygenation. That's the problem. Now, is this the best option? It can't hurt. I completely agree. If this is what you got, this is what you got. Do it. But little baby check because there's a better option. So, CPAP. Now I'm getting enthusiastic nods. Yeah. So yeah, you got to force that air in. Why is this beneficial?
Push the fluid out.
I'm hearing it pushes it open, it keeps the fluid out. All of this is true. So what does CPAP actually stand for? Yeah, so I'm going to give you the obvious answer. What does that mean? It means that there's positive pressure in the airway continuously. This is good. Why?
Because they need something to help them do that. They can't
Yes.
get it in.
Yeah, so what are rails? What specifically about the fluid in the lungs?
Air bubbles.
I heard air bubbles. Yes. So what you're actually hearing on those crackles, on those rails, is that's the sound of the alveoli popping themselves back open. So that's that little Rice Krispie sound. It's all those little alveoli popping themselves back open. And then the reason you hear it again on the next breath is because they collapse back down because of the fluid. And then they pop back open on the next one. This takes a lot of energy, a lot of force to do that. So CPAP helps with that. So we're going to watch this video. I don't know that it plays automatically. And then we're going to talk about it.
Recording again, this is a different angle.
These are little rabbit lungs.
One shot Z. And we're going to go to 15 of Peep now.
Ooh. And now this gentleman's going to take the PEEP away. Wah, wah.
Yeah. So, as you can see, some of the portions are collapsed still, even at the peak inspiration.
So, what we're looking at there, what he said in the supervillain voice, is what we're looking at is PEEP. So CPAP is actually creating PEEP. What is PEEP? Positive end expiratory pressure. So that means at the end of the breath, when you've exhaled, there's still positive pressure within the lungs themselves. That's what keeps these lungs open and aerated, and that's what's keeping these little alveoli open. So on the next breath, when you saw when he turned it up to had some PEEP on it, the lungs didn't completely deflate. So that's what your patient is up against. The fluid in the lungs collapses all those little alveoli down, and so they get that kind of at the end of every breath.
Isn't that the point of CPAP, to keep the alveoli?
Absolutely. So what you saw when he turned up the PEEP was that you still have an exhale. However, the lungs don't go back down to that sad little completely empty. You have what he calls lung recruitment. So on each breath, you can actually fill up more alveoli and keep them open. Because right now, with normal healthy lungs, your alveoli are open. And that's what makes breathing relatively easy on a normal day. With fluid, that's going to go away. Yes? Yes. Okay. So CPAP, do it, don't do it. Do it. Big check. Okay, intubation. Nobody's committing. I heard to do it. I heard a big check. We're
Less than 8 intubate.
less than 8 intubate. What if they're GCS of 12?
If they can't protect their own airway.
Now, what's going to be the difference maker in this determination? Because we said oxygen's good. More oxygen's better. If you intubate them, you can get them PEEP. So what's the difference between intubating and not intubating?
Severe respiratory failure.
Yeah, but why? This is going to be the answer to every single one of your all's answers, is why.
That's great.
Have they been an active failure? Are they tired?
So, okay.
Can they,
Are they tired? What is at the root of that question?
why are they working so hard?
Why are they tired?
Why are they tired? You figured it out. That's the key. So why are they tired? Why?
They've been working for a long time to get good rest.
Yeah, so the difference here is between oxygenation and ventilation. Oxygenation, we said, is good, but if this person is not having a problem actually getting the air in, you don't gain anything by putting plastic in their airways. If anything, we have made this patient all the more complicated because what this patient was doing for you, now you're responsible for. If you're not going to do it good, don't do it. Now, if they need it, they need it. The person who's failing at ventilation, who's actually failing at getting the breaths in, getting the breaths that they need, they're too tired to do this, they've been working too hard for too long, that person needs plastic. They need to go snorkeling. So, big check if you need it, but don't go crazy. This is not the solution to an oxygenation problem. This is the solution to a ventilation problem. Yes? Yes. Questions? Okay. What about Lasix? Because I heard Lasix. Yep. Not if you have a fever?
I'm just saying, like, forget, like, if they accidentally have pneumonia or something, that'd be bad.
Okay. Yes.
Oh, God.
Fear. I'm going to sit down because everyone's got this. So, but why? Why would this be bad if we had a fever?
Y'all keep the liquid out of the mucus and then lock their lungs up.
Okay. So yeah, not everything that looks like CHF is. People have crackles for a ton of different reasons. They have leg swelling for a ton of different reasons. And when it comes down to it, we have time on our hands. As long as this person's maintaining oxygenation, we got the CPAP going, we don't have to make this decision right now. There's a lot of things that look like APE, namely chronic congestive heart failure, which we don't necessarily treat the same as acute. We don't need to be as aggressive with it. But COPD looks the same, sepsis can look the same, that pneumonia looks the same. So asthma can look the same. And quite frankly, if you give Lasix to that person with COPD or sepsis, God knows that person with sepsis who's already 6 liters of fluid down, and now we're taking off another 2, those people actually do really poorly in the hospital. There's actually really good studies that looked at Lasix given pre-hospital, and those people tended to die. So don't. And the reason they tended to die was not because they had congestive heart failure, it's because they had something else that looked like congestive heart failure, and your x-ray vision is about as good as mine. It's not. So you can't see the fluid in the lungs. I have the benefit of doing an x-ray, so I can see exactly what's in there. I can watch this patient over time. I can throw an ultrasound on to see what's actually going on. So you don't have to make this determination immediately. You got time on your side. Let it ride. Lasix probably shouldn't be given pre-hospital. Sorry, it's not y'all. Don't be mad. Say what?
Big no.
So, don't do it. Don't do it. This is something that we will do in the hospital, but this, again, comes after some time. We have determined exactly what this is. This is not going to be the difference between somebody making or breaking it on the get-go. So, I'm never reaching for Lasix as my first thing. CPAP is. In order of preference is probably CPAP, 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 and then something else. So this is not numbers 1, 2, or 3. Okay, so what about nitro? Because I heard this before. Do it, don't do it? Oh, now y'all are scared because I gave you a big ol' X. Do it, don't do it. Vote, go.
Do it.
Do it.
Do it. Pace.
Do it if what?
Pace.
If it's,
Nitro pace.
okay. Why not a sublingual?
Stop it. I take it away.
You actually can. Well, so, okay. I came from New York. The fire department up there actually got nitro paste taken away because they kept putting it on the handles of cop cars. The cops kept syncopizing. So they're just down to the tablets. So please don't kill the cops. Don't put it. No ideas. No ideas. So yeah, I mean, nitro paste, sublingual nitro. I don't care. A nitro spray. Nitro is nitro. Do it or don't do it.
Well, if we had a mask on my face, you should probably just do it.
Okay. It's a nice option because you don't actually have to take the mask off. That's why I like the paste if you have responsible enough human beings. So yes. So is that a, yeah, we're doing it? We're slathering it on them? Okay, why? Why?
Well, thank you for taking
Why are we doing it? Why are we being cautious about it?
We don't want them to, their blood pressure.
Okay. Yeah, so we don't want them to vasodilate, lose their pressure, and then bottom out.
Well, you also don't want to fill their alveolar fluid.
Will it do that?
Yes.
No. So where does nitroglycerin actually vasodilate people? It's in the lungs or in the periphery. Yeah. So they'll lose some blood pressure tone in the periphery, like in their legs, arms and legs kind of a thing. That's where they vasodilate. And so that's where the fluid tends to go. This gives, so another thing with APE is that these people tend not to be fluid overloaded. The person who went into acute pulmonary edema, quick, isn't actually fluid overloaded, they're just fluid misplaced. So the fluid that had been in their blood vessels is now elsewhere. It is now sitting in their lungs, and we need to shift it back in. The CPAP helps with that. It actually helps push it back into the vasculature, and nitroglycerin helps with that too. So this is actually helping to fix it. This is why, again, Lasix is not a great option pre-hospital, is because the person who went into acute pulmonary edema, the person who went into this quickly, is not actually fluid behind. It's just in the wrong spot. We just need to switch it back. Lasix actually truly gets rid of the fluid. So that's better for somebody who's been in heart failure for a while. This has been building up over time, because that person, the person who's been gaining 15 pounds in the past 2 days, is probably fluid overloaded. That's somebody we need to take fluid off of rather than just moving it. So nitroglycerin helps you move the fluid that's in their lungs back into their vasculature. So that's what we're talking about here. It gets you from hot mess to normal. And again, this is the benefit that I have that y'all don't, maybe one day. And so maybe think about it a little bit, because you don't want to drop their blood pressure, but do it. Because remember, the person who's like truly in acute pulmonary edema, they probably, most of the time, knock on wood, there's no wood around here. They probably have a blood pressure that can sustain this. The person whose blood pressure is like 220 over 160, cool, game on, give it. You can dose it kind of repeatedly. You can actually give doses that mimic that of a nitro drip. Giving, with the paste it's a little harder, but with like a spray or a sublingual tablet, if you give it every 5 minutes, that's as good as my drip. So putting it in continuously, that's the same thing. You're reaching the same doses, you're achieving the same thing. So, where was I going with that? It's a good thing. Oh yeah, and their blood pressure can take it. The person who is so far in this that their blood pressure is now like 60 over 40, we have a totally different issue. And what do we do for that? Say what? Yep. Yeah, so the dopamine is actually going to help their heart squeeze a little bit. It's going to help with what their body is failing to do.
What about calcium also?
Why?
Does it help with contraction?
Yes, calcium does. However, it depends on whether we're actually at a calcium deficit or not. And so just to give calcium, I would shy away from that. Especially since this patient is this isn't the patient who has one medical problem. This isn't oh yeah, I have CHF and nothing else.
Yeah.
I only take Lasix and nothing else. This is the patient who's on 27 different meds. They go to dialysis Monday, Wednesday, Friday. They have COPD. They just had their leg chopped off from sepsis. Like this tends to be a very complex patient, so I would not give calcium off the bat, especially even in the emergency department. Even when I can check their calcium, I wouldn't. I don't think it's going to help them much. Dopamine. Cool. So, what about morphine? Come on, it's part of Mona. But would you want to do it? It dilates. Yeah, I mean this was part of heart attack protocol forever, right? Why? Why did we take it out? Partially. And people just died. So there was a trial called the ADHERE trial where they looked at people in acute decompensated heart failure. And this was one of their biggest findings, was that patients who got morphine as compared to those who didn't, they had a dramatically increased mortality. Why? I don't know. This one is something that we really haven't been able to explain, but this is why morphine has kind of like lost favor in the past couple of years, probably why y'all don't have it, is because we started to see a lot of these ill effects. we thought for a long time that it decreased preload and it was excellent, and of course we should give it, and then people kept dying. So that's not great, and that's why we shouldn't give it in acute decompensated heart failure. This is, I hate to admit it, one of the things that we finally got removed from the protocols in New York last year, even though it's been established for like 15. No big deal. So don't do it. The only reason you might want to do it is if they're having a whole lot of pain, but still, don't do it. Cool? Questions? Awesome.
Thank you.
Thank you.